Welcome back to Wake Up with Nubian Tigers Talk, a podcast brought to you by a group of Black Princetonians where we talk about issues impacting our Black communities. And with me today, as always, is my co-host, Ray Smalls.
Thank you, Michelle. And you know what? Our last episode, I learned a lot, and this is part of what we wanted to talk about during this year in terms of learning about other cultures, other allies within the BIPOC community. So we did Aida Pacheco, class of 77, last episode. She was terrific. So this show, we want to learn more about the Native American community, Michelle. So who do we have on tap for that?
Today we have talking with us Dr. Yolanda Gomez-Toya, MD, MPH, is a member of the Jicarilla Apache Nation in northern New Mexico. She graduated from Princeton in 1988 with a degree in public policy, then received a master's of public health from the University of California at Berkeley in 1991. After returning to New Mexico, she received her medical degree and completed her pediatric residency from the University of New Mexico School of Medicine. As one of the fewer than 300 Native American pediatricians in the country, she is an advocate for Native American access to culturally competent healthcare and a strong proponent for increased representation of Native American physicians and medical professionals. Dr. Gomez-Toya currently works full-time in private practice in Rio Rancho, New Mexico, and is also a pediatric consultant at the Pueblo of Jimenez Clinic, where she specializes in developmental pediatrics. Dr. Gomez-Toya was instrumental in creating an innovative school-based collaborative effort in Jimenez between the reservation school, clinic, and parents to address the needs of Native American children with learning and behavior challenges. In addition, she is an assistant professor at the University of New Mexico School of Medicine, where she teaches and supervises medical students primarily in primary care and rural medicine. Welcome to the show, Dr. Yolanda Gomez-Toya.
Thank you. I'm glad to be here.
Yolanda, as we discussed before the recording started, this season we're trying to provide more information on the other communities that make up the acronym BIPOC. One thing I think is not surprising is that non-Native people probably don't know much about any reservation, even if it's around the corner from where they live.
Except for the restaurants.
Okay, Ray. So that might be a good place for us to start. Can you tell us a little bit about the living conditions on the reservations that you are familiar with? For example, is there enough housing? Is there access to water and utilities and that kind of thing?
Sure. But first I want to just take a step back and just sort of explain a couple of things that, I think most non-Native people do not know about Native people, that there are more than 500 Native Indigenous tribes in the United States. So I just want to make sure that people know that we are a very diverse group of people. Even though we're a small percentage of the US population, just about 1.7%. And actually more people live off of the reservation than on. There is a huge urban Indian population in this country, and they have their own set of issues. But here in the Southwest United States, specifically in New Mexico, which is where I live and work, there are 23 tribes, including 19 Pueblos, 3 Apaches, and I'm Jicarilla Apache, and the Navajo Nation. And here we make up almost 11% of the population. And even in our state, we consider ourselves diverse and separate from each other. Because we all each have our own sovereign governments and unique relationships with the federal government and the state. And I don't think people know that Native American tribes are actually the only ethnic group, racial group, that have a political relationship with the US government. And that's all based on treaties and agreements over the last couple of hundred years. So I just wanted to make sure that people know that it's so diverse, and that I really can just speak to what I know, having lived in, and I grew up here, born and raised in New Mexico. And I'll speak mostly to that. But back to your question about housing, access to water, and utilities, it is true that many of our communities still lack basic infrastructure to provide adequate housing and clean water. Now, nationally, 40% of Native people live in overcrowded or physically inadequate housing conditions, which can include poor quality of homes, lack of running water and plumbing. In fact, on the Navajo Nation, 30% of households do not have running water.
Wow.
Clean water is always a huge concern on the res. And in fact, when I was growing up on the reservation, we always had to make sure we had clean drinking water. It was always a priority in my family. I remember going to town and being in places, other people's homes, where you could just turn the faucet on and have clean water that you could drink. Like that was a foreign concept to us growing up. So we would fill up water containers weekly and drive them out to where we lived. And our whole relationship with water, my parents made certain that we knew not to waste water. I mean, we didn't have swimming pools, we didn't use water guns, we didn't do any of that because water was sacred. And we spent a lot of time collecting it and keeping it clean. The other thing too is access to a healthy food supply. That's also inadequate. In some of our communities, our people shop at the local gas station, the local convenience store. That's their only option to buy food, which in general is junk food. There's not a lot of fresh food there. So that also, I was thinking about this question. Why don't most non-natives know about us? And even, when I went to school at Princeton, I didn't know that there were communities in Princeton that were Native. But a couple of months ago, one of my Princeton classmates sent me a course material that her 10-year-old son brought home from school about Native Americans, and they live in Maryland. And I looked at it, and it was so outdated, full of stereotypes, misinformation, that honestly, it almost made me want to throw up. I just couldn't believe that we are teaching our kids something that's just wrong. So my suggestion to people who want to know more about Natives is to do a little research themselves by starting focusing on the land that you live on. What nation of people live there? Who were they? What language did they speak? And what happened to them? And I think right now in education, with all of this about sensitivity, about what we teach in a historical sense in our classrooms, we're just going to have to bite that bullet, and we're going to have to talk about what happened. And for Native Americans, I think that's so important because of this misinformation that you're talking about. And it's almost like that we don't exist anymore. But I want people to know that we still have communities here. We have, we're here, we're still living, we're still working, we live right next to you sometimes. And so it has to come from other people too. I mean, I do a lot of education in my work, but other people do also have to keep an open mind and just be honest about our history.
So that's interesting. It would be New Jersey, because in New Jersey, there's a significant Native American community, and they've been there and they're active. And so there's really no reason for schools to not have good material on that. The other thing I think is interesting about that is, here in DC, we have the American Indian Museum, and the displays have information from the Native perspective on the cards, as opposed to what you would get in a regular white museum. And it's often entertaining for me to just sit on a bench and watch white tourists read the placards, because you can see that moment when they realize the story that's being told in the museum is not the story that they've learned.
Yeah,
right?
this isn't what I remember reading.
Right. They'll tug on each other and they'll point to the placard and they'll just huddle around and read it, because it's not the story that they were told when they were growing up. So education is so terribly important. I agree with you on that.
It is, and real education about real facts. Not every time Thanksgiving comes around and I see the little stereotype pilgrim, the little Native American girl giving food to the pilgrim, that's not what happened. Let's talk about how this country was settled.
Yeah.
You know, and it's a complex history. I mean, one of the questions that you had asked me, you know, why are conditions so poor on the reservations and what factors led to this? And it's a complex history of how we got to this
Yeah.
place.
No.
And that takes more than 30 minutes.
It's yours is a complex and brutal
I-
history, much as
Yeah.
Black history in America is.
And one of the things that I want to do is say, take my tribe, for example, Hikaria, and let's just talk about what happened to us. That's a whole course right there. So it's a very complex history. But if you go back and think about how this country was settled, the mindset of the colonizers at that time was that this country was empty. You know, there was just, you know, beautiful land and animals and stuff, when in fact we had millions of indigenous people here with thousands of different tribes, different languages, different traditions and cultures. But they didn't see us like that. They pretty much saw us as the same as animals, you know, to be killed or driven off. And so the fact that so many of us have survived more than 500 years of constant calculated efforts to kill all of us is an amazing feat.
Mm-hmm.
So the US government in its early years did make some effort to negotiate with tribes. But what we have now with the formations of reservations is really just a shadow of who we once were. And so right now, I think we have about 326 federally recognized reservations in the US. And that brings up some other issues too, is there are federally recognized tribes and there are state recognized tribes. And there are groups of Native people who are trying to get one of the two or both of them. And that's a whole nother podcast in terms of who is Native American,
Right.
who is Indigenous, because, you know, my work with the Princeton Alumni Council, you know, I was the founder of the Native Alumni of Princeton group. We had a lot of Hispanic and Black and white people say, well, you know, I'm part Native and wanted to be part of our group, which is fine with me. But again, a lot of them come from communities not from a reservation, not a federally recognized tribe. And I think in New Jersey, they do have state recognized tribes, not federally recognized tribes.
Right.
The Lenape Delaware people.
Yeah.
So it's really kind of a complex issue. It's one that I'm always learning about, but you know, that's when we talk about, you know, knowledge about Native American people, that's just an ongoing process. It's going to take some time.
Okay, so let's sort of continue to focus in on the conditions that lead up to the COVID situation, which you're going to talk about. Some years ago, I read Russell Means' autobiography, Where White Men Fear to Tread. And in the book, he has several horrifying passages where he's describing medical treatment or the lack thereof on the reservation where he came from. So so to start getting us into thinking about COVID, can you talk about what the medical conditions were in the areas that you were practicing?
Like I mentioned before, it's complex and it's different almost on every reservation. So health and medical care, and I'm going to use the res, because we talk about the res versus the reservation. It's very complicated. Now, while nationally, the Indian Health Service, which is a government-led program, they're charged to provide comprehensive medical care to tribes. And that was all part of treaty agreements. That's all legal of their responsibility to provide healthcare to us in exchange for taking our land. But this whole program, the Indian Health Service, is and has been inadequately funded and not staffed correctly. And that has always been the case. And I'm not gonna diss the Indian Health Service, because I know, and I work with a lot of providers and staff from the Indian Health Service, and they have a hard job. But I think what people need to know is not every reservation has its own Indian Health Service clinic. Some people have to drive 2 hours or more to access basic health care at other clinics, whether they're Native oriented or not. I actually, and I think in my introduction, my full-time job is in a private practice clinic in Rio Rancho. So I don't actually work full-time in a tribal clinic, but I have a lot of families who drive 2-3 hours to see me because I'm one of just a couple of Native pediatrician. And they're just people that I know, that I grew up with, the word gets out. And they tell me that to get an appointment with their Indian Health Service clinic, it was impossible. They couldn't get it. It was going to take 2 months. And so it's easier for them to drive the 2+ hours to come see me. But some tribes have actually taken over and run their own clinic using those Indian Health Service federal funds, including the Pueblo of Jemez, which is where I have worked for the last 6 years as a consultant pediatrician. Now, just to go back, when I first wanted to be a physician, my goal was always to go back home and be a pediatrician at home. And that just didn't work out for many, many reasons. So I kept, during my whole career, my education, residency, I have always kept in contact with Native communities that are close to me, and especially my community, Hickoria. And that's why I do the consultant work, is because I really feel like that's I needed there. But the tribally run clinics, like the Pueblo of Jemez, have done an amazing job because they're more similar to sort of the national public health clinics out there. But to me, they're more responsive to the community and they provide more comprehensive care. You know, so I think when people, this is the other thing that I hear sometimes, which kind of upsets me, is people tell me, well, you're Native American, you guys get free health care. No, we don't. It's not free.
Right.
And the access to this health care is sometimes non-existent or so difficult for people to get, that it's inadequate health care. It's not real health care like they have. And it's kind of, it's upsetting to me because people feel like, oh, you have free education. No, we don't have free education. Like my scholarship to Princeton, it wasn't free. And so, again, that goes back to the misinformation. During COVID, and of course, we'll talk about this, COVID really made it clear that we were completely underfunded and understaffed.
Yeah, so let's get there, Ray. Take us into the COVID question.
Well, she had mentioned earlier about just people getting appointments for her having to travel 2 or 3 hours. But during COVID, Yolanda, people were going from one state to another during this process. And was that your experience as well, that some people were coming from other states to get care? So,
no, I didn't see that in the Native community. I saw a little bit of that in some of my patient populations that are not Native, but it was only because the lack of understanding or lack of money, financial means to be able to go to a different state. You know, I think we need to go back to sort of the basic reason of why our communities were hit so hard by COVID and by any epidemic. The flu, influenza every year hits us hard. Poverty. You know, sometimes in a overcrowded house, it's multi-generational, 12 to 20 people live in a 2-bedroom house. They share one car. So we didn't have the luxury of being able to do that. Mm-hmm. We just didn't have the money to do that. That wasn't an option for us. What people did when COVID hit, and I'll go back because, you know, COVID, when we first started hearing about COVID, personally and professionally, what I saw at the beginning of COVID was a real fear amongst Native people, especially for us healthcare workers. We knew that our healthcare was not adequate. We knew that our people in general had high rates of diabetes, obesity, heart disease, and we knew that it was not if, but when COVID hit our communities, right, it had the potential to be detrimental. We knew this, and I was scared. And other physicians were scared, other medical providers were scared. But this is the interesting thing that happened when COVID first hit. At the same time, because I got to see both sides. I got to see private practice, non-Native families and, you know, staff and other providers. And I got to see, you know, tribally based the same thing, tribally based. And it felt like non-Native people did not take this potential pandemic seriously. And I think this is why it got out of control so quickly.
Mm-hmm.
Exactly.
There was this whole sort of, we're living in this bubble in the metro area, and people were talking about COVID like it was over exaggerated. And I think I got told not to use the term fear, or I'm scared, because that's not really the case. That's not really happening. And this is from other providers to me. And I was like, y'all don't understand what's happening in the tribal communities.
Mm-hmm.
And there was this whole disregard of understanding of how COVID can affect communities of color, how it can affect, communities that are poor, that don't have that don't have the access to healthcare. And talking to you all and talking to my other providers that work in other parts of the country, it wasn't just us. It was, Black communities, Hispanic communities.
Right.
So that was very eye-opening to me. But I was actually pretty proud of the tribal communities, because within a couple of weeks, they took on, wearing masks, as soon as it was available, testing community members, making sure vaccinations were available to the people quickly. They were on top of things. But then I would come back to the city and people are like, well, let's not wear masks right now. Well, so it was just this weird sort of, looking at the world, with two different sets of glasses. But I really feel that, we were not taking this seriously in the beginning.
Well, the tribal communities know what viruses from outside
Yes.
can do to the
Yes.
population.
It's a little bit of history. There's a little bit of history there.
And again, let's go back to the history,
Yes.
right? Because,
Yes.
the estimates were that 95% of indigenous people in this continent were killed by disease, even before they ever met a colonizer. That, these massive waves of smallpox, measles, killed entire communities of tribes. And so with that memory, our people are like, okay, our antennas are up. We got to take this seriously. But what I saw sort of around them was, oh, they're overacting. This isn't that real. And that was hard for me to take. It was hard for me to be, sort of, okay, I'm a provider here. I need to educate people. And I still think some of that is going on, especially now. Our governor just lifted the mask mandate indoors just a couple of days ago, and all of us are going, oh heck no, we're all still wearing our mask, And I'm pretty sure the tribal clinics they're not gonna let up. I just went to a funeral 2 weeks ago. My brother-in-law passed away from COVID.
So,
and I'm just thinking, we're not out of this yet. Where did we get this information? But again, part of it is political. Part of it is, people want to get on with their lives, and I understand that. I do. I want to get on with my life, but we're not ready.
And Yolanda, that triggers for us, especially in the Black community. We know we lost a lot of our people due to this virus, but in the Native American communities, what were the percentages like from people passing away from this virus?
That brings up an important topic of data collection and analysis. We won't know those numbers specifically for a couple of years because of the difficulty collecting data and having someone analyze it. We do know that we do have some initial numbers that the mortality rate has been estimated at about 2.8% higher for Natives than all other populations. I personally think it's higher than that because of the way deaths are handled and reported on some reservations, especially here in New Mexico. We don't have coroners on the res. It doesn't include the secondary causes of death, such as the increased illicit drug use and overdoses, alcohol deaths, suicides, they were all exponentially increased during COVID. And that was all because it was all made worse because of lack of access to healthcare for these patients. So I think it's much higher. We won't, like I said, we won't know that for a couple of years. Some people, some tribes here in New Mexico bury their own. So we don't take them to the funeral home to get processed. They bury them the next day. And so a lot of those people might have COVID. And that could be a secondary, that having COVID just makes everybody's existing health problems worse. So ask me the same question in about 5 years, and I will have more adequate data. All I can say is it's higher than others. And part of it is we can't collect the data fast enough, and it's not being collected correctly.
Who would collect data?
That's the big question. So, if you live in the city, they'll test you, and, if someone passes away, they test them. And, then there's this, way to register and collect information. Who would do that? Who would do that on the reservation? That's a good question.
Okay. Yeah, I would also imagine that same as in the Latino communities everywhere, that large families that don't have a lot of space to live in couldn't adequately distance themselves in order to protect against transmission inside the household. So were you seeing some of that as well?
Oh, huge. Like I said before, the issue with the housing and the inadequate housing, where you had up to 20 people living in this small home, and it was multi-generational. So you could have great-grandparents down to newborn infants living in one family home. It spread like wildfire. And I think for tribal communities, what they did initially did help. We weren't seeing huge numbers of COVID cases initially, probably for like 6 to 8 months. But once it got into the communities and into households, then that's when we saw the big spread and the increased deaths. Now, on my reservation on Jicarilla, I think we've had a little bit over, for a population of 3,000, a little under 3,000, we've had about 30 COVID direct deaths. But that doesn't include, again, the secondary effects of COVID. And, people who are on dialysis couldn't get to their clinic because the drivers had COVID, the dialysis clinics closed. Those people died. Again, I lost 2 nieces, one in a car accident because she was trying to get home before quarantine. They had at night that I had to be home by like 8 p.m.
Curfew.
Curfew, thank you. She died. She died in a car accident because she was racing to get home. And then 8 months later, her older sister died from abuse, issues related to abuse because of the sadness of having to deal with her sister's death. I mean, all of that is indirectly related to COVID, and it's going to take time to sort of analyze and look at what really happened.
Sorry to hear about the deaths of your family members.
No, thank you.
Okay, so we kind of get a sense from you about the health issues that COVID had on reservations. What about education? What about online learning? Well, I should ask the question: how much of a sense of online learning can you give us about, let's say, your particular reservation? Because, I mean, obviously, if you're underfunded for healthcare, you're underfunded probably for education as well.
Yes, and it's unfortunate. My community, our schools on our reservation is the worst school district in the whole state. And initially there was a lot of chaos about the online learning thing because for our community, we actually didn't have access to the internet. And cellular service is very spotty. So when I drive home, I tell people, I'll call people, I'm leaving now, I'm going to be out of cell service for an hour because it takes me almost 3 hours to drive home. And
Wow.
there's like one gas station, there's like one stoplight on the way, and no cell service for most of it. So on our reservation, initially, the only place where parents could take their children to do and download the online work was the parking lot in front of the tribal jail, because they had internet and they could access the
What kind
internet
of
sitting.
example is that?
Why is it there's always seems
that
to be
imagery is
internet?
just
Right.
horrible.
There's always seems to be internet around the prisons. Why is that?
Right? Why? I know they have rights too, right? But and when I heard that, it just astounded me.
Mm.
But one of the things, let's turn this around. If you could identify one positive thing about COVID on our reservation, is that it brought a lot of attention to this issue. This is a problem, right? But what happened is it brought a lot of attention, and now there was some federal funding available. The tribe actually is installing the internet to most of our households. Now that wouldn't have happened if we didn't have COVID. But we're already almost 2 years behind in terms of the academic learning of our kids. I wish we could do a do-over. Let's start over 2 years ago.
Yeah.
Because I think a lot of our kids are behind, even though now we're just getting internet now. It's been 2 years. We're so far behind, like a lot of other kids are, but we were already behind that.
Right, beforehand.
Yeah. One of the other things that happened is the project that I work at Hamas, and why they hired me, is to see their kids who have learning issues, learning disorders, things like ADHD or dyslexia. They don't have specialists to work with children to identify, who has these issues, and then I would work with the school, with their special education team, their speech pathologist, to come up with a plan for these kids. Some kids needed medication, not all of them did, but that I was pretty proud of that program. But what COVID did was stop that, because the kids were not in school, they were doing online. They had closed the clinic for a while just because we couldn't figure out what was going on with COVID, and severely restricted patient visits. Well child visits were sort of put to the side, to see the sick patients. So a lot of those kids that I was following, I don't know what's happened to them. About a year ago, I made the difficult decision to take a sabbatical from my job at the Hamas clinic, only because it was so difficult to work there. And it wasn't anybody in particular. It was just what COVID was doing to clinics. They were closing the clinics. It was difficult to get appointments. And I felt like I wasn't doing anything. I couldn't see my kids. So yes, it has affected the education of our children. I hope to get back there this year as things are opening up a little. I was working on a project with my tribe, with Hikaria, to create actually a 0 to 5 year program to get our kids ready to start kindergarten, because we don't have enough services from age 3 to 5. There's we have the 0 to 3 with the early intervention, but we didn't have anything from 3 to 5. So our kids were starting kindergarten with, classified as English as a second language. Even though most of our kids speak English, their vocabulary just wasn't there.
Too limited, yeah.
Very limited. And so, again, one of the secondary things I think that happened with COVID is all those programs that we were developing, that I was working on, just stopped.
Right.
Because all the focus was on the pandemic. And again, we're not going to really see what effects that has had on our children for a couple of years. Now we're seeing in the general pediatric practice, we're seeing that brain fog. We're seeing possibly some developmental delay in some of the children who've had COVID disease. And again, that's a whole separate discussion to be had. And I bet you $1 million, none of that is going to be focused on Native American children. And that's what I do. as a Native American pediatrician, I always try to advocate for Native children, because we're never included in studies. We're never included in all this stuff. So again, ask me in 5 years, we should have this discussion again, and I'll have a lot more information.
Yeah. Well, that actually takes me to where we wanted to end up with you, which was, we read the Paul piece that was talking about your experience being a Native American pediatrician physician. And I just wanted you to talk a little bit about how you're working to encourage more.
Excuse me, Michelle, let our listeners know what PAR stands for.
Oh, Princeton Alumni Weekly, sorry.
Okay.
Not everybody reads that. But just to get a sense of what is the effort required to get more Native American physicians?
It's difficult. And we just talked about how our kids start kindergarten 2 years behind, and they never catch up. And that's a problem. In general, though, it's always difficult to recruit any healthcare provider to our rural communities, because we're so rural. It takes almost 3 hours to drive from Albuquerque to my community.
Yeah.
And you take somebody from the East Coast, and they come out here, and you get in a car and you're just like driving through the desert for forever. And they're thinking, do I really want to live here? And so that's always been a problem. But that's why I try and mentor Native American high school and college students, because the data shows that they're the ones who are most likely to go back to our communities to live and work. And they understand what we're going through.
Mm-hmm.
But again, COVID has kind of slowed down the mentoring again. The students they couldn't come physically in to shadow me because of COVID restrictions. I myself was busier than usual with clinics, and especially in the last, that little more than a half a year when COVID hit kids, because initially COVID wasn't affecting children at all. And we were like, what the heck? But recently it's hit us hard. So kind of like what I was talking about, the project that I was working at Hamus with the kids, that got kind of put, to the side. The same thing has happened with me trying to do the mentoring. A lot of kids are still doing online school, especially high school. And it's been difficult to try to get them, because I think with mentoring and trying to get young people to want to do medicine, they have to see what we do. You have to physically see what happens in an exam room. And you can just see it in a kid's eyes when they see their interaction between my patient, my families and myself in that small room. You could just see it in their eyes, like, I want to do this. And that's what they need to see, is they need to see a Native person, a woman,
right,
do this work as a physician. And I had the best compliment from a college Native student, a woman, and she shadowed me for about 2 months. And one of the last things she told me, because we always do a little exit interview, is she told me, I just really was impressed with your confidence. And that kind of took me back, because I'm an older person, been around for a while. And she says, it's just nice to see a Native woman talk with confidence the way that you did to these families, and they trust you. And that trust relationship that we have between us, she said that really made her want to pursue medicine. And she's in medical school now.
Positive images.
It's those, they gotta see it. And I think that's the hardest thing is, and especially with COVID, it just hasn't happened. I think I've had one. And everybody else, it's just been difficult. I feel like I'm, there are programs around the country that are focusing on trying to get more Native students interested in medicine. I do teach. I'm a community faculty at the University of New Mexico School of Medicine. So I do teach current medical students and residents. And I always try to get them thinking outside the box. Now you're going to be a physician, in a couple of years going to be a doctor. You have to open up your practice and yourself to, and not, I don't know where they're going to practice, but Native, Black, Hispanic students that want to shadow you, let them shadow you. You know, so they see what you do. They need to see us in action.
Yeah.
But again, it's complex. It's multifaceted. Not many of our kids even graduate from high school, which is sad. We have the lowest ACT scores. We don't do well on test taking, but all of that has to go back to basic infrastructure, education, getting good teachers. Motivation is a huge issue. One of the things I want to work on with the 0 to 5 program is making sure that women, even before they get pregnant, are they in a healthy place to have a baby? You know, what do they who do they have to support them? In New Mexico, most of our households with young Native children, they live in poverty, and they have single mother raising them. So in this program that I'm envisioning, and I've been working with the government, the tribal government with, is to make sure that women are in a healthy place physically, spiritually, mental health, to get pregnant. And during the pregnancy, are they supported? You know, is this fetus growing in a safe environment with adequate nutrients? You know, I just told you that most people shop at the local convenience store. You know, how is this affecting their brain?
You know, this is so similar. I won't say the same because it's not the same, but to Black and brown communities everywhere that have food deserts, for example.
And their food deserts are a lot different than our food deserts.
Their food deserts are different, but you're still talking about the same issues: not sufficient nutrition, not being able to get fresh fruits and vegetables, and those kinds of things. So it is complex, but that's all part of the process we're trying to get to. Where are we similar to each other, and how can we work towards that? So Yolanda, I'd like you to just wrap up with what are some final thoughts you want to leave with our audience?
You know, I always try to push the diversity thing of Native people, you know, and having people sort of reach out to their, you know, finding out who lived there on their land before they were there. The understanding that, you know, Native American people aren't just, you know, we're not like on TV and in the movies, these stereotypes that I hear about, wearing buckskin, wearing feathers. We're doctors, we're nurses, we're teachers. I think people need to sort of look at us as human beings. You know, I still feel that people look at us in history books, and I think we're not going to be able to get the support and the respect until we as Native people come out as well and say, look, we're still here. And it's interesting, I tell you the story about me going to an art exhibit up in Santa Fe, and they asked me if I was an artist. And I was just there supporting my cousin who was an artist. And I told them, well, actually, I'm not an artist, but I'm a physician. And they just looked at me and walked away, because that whole concept of, well, Native people can't be doctors.
Right.
You know, like that's what angers me. You know, to the audience, we're everywhere. We're your neighbor, you know, we're shopping next to you at the grocery store, you know, not to look at us as historical remnants that don't exist anymore. You know, in New Mexico, I'm lucky to be in communities where people still speak their language, still practice their religion, their dances. And I feel very fortunate about that, because I've lived on the East and the West Coast, and come back here and I'm like, this is cool. I like living here. You know, these are my people. We're still here. But you're right that communities of color have very similar problems. We talked a little bit about voting rights, you know, and it goes beyond health and medicine and public health, you know, and racism, poverty, you know, those are all things that connect us. And I really look forward to working more outside of what I do. And that's why I like doing these projects that you invited to me. And I really appreciate you giving me the time to talk today.
Oh, no, you've been wonderful. And you really, Yolanda, we are so committed to the education process of our older people in the BIPOC community, because we have to, in these terrible times we're living in, understand each other so that we can be effective allies and move us out of this terrible white supremacy that we're all being all suffering under. So thank you so much. I'm sure we will have you back. Almost all of our guests were like, no, you have to come back.
Well, and in earlier than 5 years, like you said.
That sounds good. That sounds good to me.
We just want to express our appreciation for you taking out your time to talk with us this evening about these very, very important issues. Thank you so much.
Well, thank you for inviting me. It was a pleasure.
If you enjoyed what you heard today, visit our website, nubiantigerspodcast.com. In addition to the podcast, we also post a resource page for each subject to provide additional sources of information. Follow us on Twitter. Our handle is @NubianTigers, written as one word. We're also on YouTube on the Nubian Tigers podcast channel. Our podcast is hosted by Anchor FM, but if you have a favorite podcast app, we're probably on it. Just look for the Nubian Tigers Talk. Looking forward to sharing some knowledge with you next time.
Wake up, wake up, wake up.